Okay, so today we're talking about taking a history. Has anyone taught you how to take a psychiatric history so far?
I've had a little
A
bit.
bit? Okay. So we'll go through how I think a history should be taken, which may not be quite the same as your textbooks. But so just a brief case to illustrate how to take a history. We're going to talk about Dave, who's 40 years old and now lives alone in a one-bedroom flat, married but recently separated, two teenage kids who live in the family home. He's always been in work. Now he works in a family tooling business, and he came to our attention after arriving in A&E, having collapsed at work. So, how do you take? How do you construct an interview? So, really, the aim is to take a history, conduct an examination, think about any relevant investigations, then consider a differential diagnosis, reach a diagnosis or formulation. Very importantly, conduct a risk assessment, and then have a think about how you treatment and management. So in a psychiatric history, so you may be familiar with these headings for psychiatric history. So we'll go through them, and I'll explain why I do things in this order. Very importantly, demographics need to be considered first. So when you're presenting a case, the first thing you should say is, this is Dave. He's a 40-year-old married man who is recently separated, living alone, and is currently in full-time employment. So that needs to come out first. Now, all of the textbooks that you'll read will advise you to start with a presenting complaint and history of presenting complaint. I mean, I would argue that in taking a psychiatric history, it's better to start with background and something that is you need to work up to talking about sensitive topics. So if someone presents following self-harm, probably you need to build a bit of a relationship with them first before asking about the self-harm and why they've self-harmed. So what I like to do is start with something fairly factual, their medication history. So what medication is he taking, why, and importantly, does he actually take them? And don't assume that just because a patient is prescribed a medication 3 times daily, they're actually taking that. And do they think there's any benefit? And so Dave is prescribed lansoprazole, and he said he takes that and it's useful. He's prescribed citalopram, and he said, when you question him, he says that he takes it occasionally. If he's feeling really down, he'll take 2 or 3 in the morning, which is not how it should be taken, but unless you ask this question, you won't find out. And does he find them useful? No, he doesn't. An important consideration for when you're working as an F1 doctor, somebody comes into hospital and they've not been taking this medication. Should you just restart them? The answer is some medication needs to be retitrated, and you need to be careful about just simply restarting medication if the patient's not been taking them. So then the next heading is past medical history. He suffers from gastritis, but there's been nothing else significant. Next heading, past psychiatric history. So he reports on questioning that he struggled with depression for years, and he's been suicidal for years. He's not had any admissions to psychiatric hospital. We will find that alcohol is a significant factor in his presentation, and the important negative is that he's not previously ever had a detox. Next heading is family history, and he reports a very strong family history of alcohol problems. He describes nearly all of his family as drinkers, his father, uncles, grandfather, and two of his brothers. He said that his sister is bad with her nerves. She would probably receive a diagnosis of anxiety or generalized anxiety disorder. And then he says that his brother and sister suffer from bipolar disorder. Now, so it's always good to be a little bit either skeptical or questioning when patients report this, and when you might want to question him further about the validity of what he says these diagnoses are. And so in particular, I would want to know, has his brother or sister ever been admitted to a psychiatric hospital with a manic episode? So be open-minded about when patients report their family history. So why do we take a family history? So here you can see that nearly all mental disorders have very significant heritability. So particularly bipolar disorder and schizophrenia have heritability rates of 85% or higher. And if you look at alcohol dependence, heritability rates for addiction and alcoholism are quoted at about 65%. If anything, I would say that's an underestimate. Okay, so next is personal history, and this is just a rough personal history. So how was his childhood? How was his schooling? How was his work history and his relationship history? And you can see that given there. This very important in anyone, everyone that you take a psychiatric history, from whom you take a psychiatric history, to take an alcohol and drug history. Ask everyone, not just those who you think might have a drug and alcohol issue. Because you risk missing people if you don't take the history. So with Dave here, so an alcohol history, this is how you might structure an alcohol history. So take a longitudinal history from his first drink, and here you can see the progression of his drinking, and you can see further progression in his drinking in his through his 30s to much more harmful drinking and drinking that's out of control. And then most recently, following his separation, his drinking has become out of control. He has lost his relationship. His family have told him not to come into work, and these really were the two things that were holding things together for him. And since he's lost both of those, he's drinking all day and every day. So he's drinking a 70 cl bottle of vodka per day, and then either a couple of cans of a super lager. I think he drinks Skull. This is a picture of Special Brew. Or he will drink a litre of white cider. White cider that's commonly referred to as the cider that's never seen an apple. And then, particularly with alcohol, you would want to take a history of complications, particularly looking at alcohol-related brain damage and alcoholic liver disease. With drugs, you might want to consider complications that are specific to the particular drug that someone's taking. Next, a heading of premorbid personality, or an analysis of their personality. This is not something that is widely done, but I would suggest it's very important. And if you don't know how to assess someone's personality, then using the Big Five personality inventory is a very good way of starting that. If you don't know about neuroticism as in the study of psychology, I'd suggest it's important to know about. So you'll notice that I leave the presenting complaint and the history of presenting complaint to the end. So for a couple of reasons. One, it's good to build up a rapport with the patient before getting on to sensitive subjects. The other reason is that in psychiatry, as well as in medicine generally, we deal with chronic illness, and the real question that needs to be asked is why now? And with our man in this history, the why is relating to the breakdown of his relationship. So that's how you take a history. There will be a mental state examination required, which will be covered in a separate lecture. I've just put this in just as a reminder about the examination for signs of alcoholic liver disease. Before we get on to treatment, important to consider risk assessment, again covered in a separate lecture. The point to make here is that whenever there are children involved, you must comment on any risks to children, and it's important to state that you consider there are no specific risks. Then differential diagnosis, and then I've just included here this year as a rough idea of how to structure the management. I don't know if you've seen this grid before.
We've done biopsychosocial.
Yeah. So biopsychosocial and also consideration of acute, mid to long term, and I would suggest it's important to consider a spiritual or existential dimension, especially when considering the neuroses more broadly, but again covered in another lecture. Okay, that's it.